Hello. Okay, you're here. So you have to ask little more about cardiovascular. When she was child, did she had any cardiovascular problem in the heart? Then I would have told you that yes, but it was not the cause actually, but just to make you, I would have told that she had a small hole, but it closed by itself like this. Okay, but you did not ask. So this is an acute presentation. We have to search for the differential diagnosis here. Okay. Medications you asked, I told Panadol, and also recently thyroxine was started, but I did not tell you this. Allergies you asked, no allergies. Nutrition and diet was asked. Anyways, her centiles were given in the information. If it is given, if you want, you can ask. If you don't want, it's okay.
Okay.
Okay. Next in systemic review, you should go head to toe. I think you covered all. You asked about pallor. You asked about any other weakness. Because she's 13 years old, you should also have asked about any behavioral problems before. But you covered this in social history. You asked about school, but also ask the leading question like in house if she has any problems with the behavior, because she's 13 years old. Okay.
Yeah, okay.
No, you asked about joint pain, blood transfusions. I think blood transfusions you asked because of sickle cell anemia, or what you wanted
Yeah,
to.
for sickle cell.
Okay. So skin rashes, what you wanted to, what was your differential here in your mind?
Like any bleeding tendency, anything to find out
Okay.
underlying cause for this.
Yeah.
And also could be because of some like no hyperpigment cafeolus spot or any underlying illness to find out. Sometimes it could be neurocutaneous.
Yeah, you asked about patches on the skin. This is for the neurocutaneous markers, like for neurofibromatosis and other things. Skin rashes, you asked, could be for the petechiae purpura. And also SLE.
لا لا عارف بس واحدة امشوا انتوا سبقوني وانا هاجي.
Astaghfirullah. Okay, SLE. Also, you know, so the butterfly rash on the face.
Yes,
but you asked, so all these things will be covered, and P and Poo was asked. But always not to miss anything, it's better to go head to toe. But you asked, I think you covered lots of the things. Delivery was asked, development was asked, puberty was asked, which is good, vaccination, and past medical history also was asked, which was not significant in this child. Family history.
فظيعة.
I will remove her from the meeting. I'm sorry, huh? Because this will trouble me too much. Next is you asked family history and social history was covered, especially about the drugs, smoking, alcohol, which can be an cause. So regarding the regarding the differential diagnosis, here you will give the differential diagnosis of stroke. So along with the acute CVA and space occupying lesions, you can also tell, I want to rule out any cardiac problem. Okay, cardiac is also important here, and some AV malformations or all those things is important. So you will give your diagnosis will be stroke for further evaluation, because by the history you did not get anything significant why she got this, because and it is less likely in 13 years old, right? Unless there is any significant past medical history, like she's known case of sickle cell disease or cardiac problem or anything, or SLE or some AV malformations, or she's known case of Sturge-Weber syndrome, all these things. So you will give a stroke for further evaluation, and I want to rule out the cerebrovascular accident, space occupying lesions, any cardiac problems in her, any AV malformations. And still there is a list, maybe I forgot. I will tell you. And also you should rule out the sickle cell disease. For sickle cell, along with the transfusion, if you want, we can also ask about their background. Okay. Next is the, yes, in the management first, even though she is stabilized now in the ward, you can just tell that if we receive this child for the first time, we will do the acute management, ABC, vital signs, CNS examination. What you missed here was the fundoscopy. Okay. Bedside.
Yes.
Bedside fundoscopy
Yes.
has to be done because she is vomiting and there is headache, acute now. There is some mass effect here, maybe, we don't know, you have to further evaluate. So you will do the fundoscopy was not told, but you told the BP. Then I think investigations were fine since there was no fever or anything suggesting of infection. But still, if you want to rule out infection, you can also do the labs for that. Okay, but don't tell it as you said is more important here is CBC, coagulation profile, blood sugar, KFT. What about LFT? Why you wanted to do LFT here?
LFT, any actually chronic illness, usually we do routinely. Second thing is liver function can have this coagulation problem. So if any liver problem underlying.
We are doing PT-PTT, but still you want all LFT. I'm not sure. I'm just asking. Okay.
Yeah, usually routine for all chronic or acute illness, usually we do, but I don't know.
Okay. But the diagnostic investigation here is the MRI, brain. Along with it, sometimes they also do what else?
Maybe EEG?
No EEG because there is no seizure here. Anyone else?
Okay, yeah, MR angiography.
Yeah, MR angiography. Because to see the arteries.
MRA and MRE.
What? Yes, Dr.
MRA.
MRI and MRA.
Yeah, MRA and MRE, I think this is.
Okay. This is the investigations and management. I think you covered. After the basic management, you will involve the pediatrician. Means you better to say your consultant you will first involve. Okay, consultant, then the neurologist, then all were involved because here physiotherapist will come, occupational therapist, speech and language therapist will come, psychologist because they are in depression now, she may have problems, she may take time to improve, education, dietitian. Now what do you think, how about the prognosis? She will recover well or there will be some sequelae?
Yeah, prognosis could be, maybe she will recover also, but there may be some sequel. It's difficult to answer.
Yeah.
For her.
So do you have an idea?
I think prognosis, I was reading that they were doing that. Prognosis, most of them is good, but except the few percentage, I don't remember the percentage, they have the sequel in neurology.
Actually, today, Dr. Krishna was supposed to be the role player. Okay, he did not come. So I just made this case to practice only. This was a case I saw in my hospital recently, which was a real case. That's why I did. Actually, she did not had any past history suggesting like sickle cell anemia or anything. Or any cardiac problem or anything. She was for evaluation, doing all the investigations to check out what is the cause. Okay, and sometimes they say that it can be idiopathic also with no explanation. Okay, and the MRI in this child.
They say the prognosis, most of them they cover. almost people recover from Guillain-Barré syndrome. The mortality, as I told you, I don't remember the percentage, but the mortality rate is 4% to 7%. And in this, people are able to recover in 6 months. Mortality is like 4%.
There is some problem. I can't hear you, doctor.
Okay.
Yes.
Hello?
Yeah.
What?
Apart from this,
I didn't.
wants to add anything?
Other causes?
Yeah.
Maybe this mainly the vascular causes, many causes are there, like this moya and maybe some metabolic like mitochondrial disorder who present with stroke.
But I think don't for the hemiplegia clear, the keep the differential diagnosis as infection and metabolic down.
Yeah. No, now you have asked, that's why I'm telling like other causes, but usually. What was the cause for this child? What you told? This curve, your case?
Still, I did not go back and check. I will check and.
Hello, Dr. Noor. Just I want to ask if we have to do the other investigation like hematological investigation, protein C and protein S, and factor 5 and all of these things, or it's the details have to be done with the hematological team?
Yes, here the basically when you start with what she said is more than enough. We will do the CBC coagulation profile to start with to admit the patient. But if there is no clear clue, suppose if this was a child with a stroke with sickle cell anemia, we would have gone for exchange transfusion and other things. So if you know the reason, it's okay. If you don't know, she has to be admitted and worked out completely.
ECHO has any rule as a workup for this child? Maybe she has some shunt, intracardiac shunt, ASD, BFR.
Yes, because if she had congenital heart disease also, can be. Yes, if there is nothing, you have to rule out. Cardiac is very important here, ruling out cardiac things. Or she has see here it's written causes include cardiac, hematological. So you will divide the causes like this. We will go through this so that we will get.
Okay, last question. During the history, I don't know, in UK they are doing screening for neonate for echo, so we can ask the mother if they found anything during the neonatal screening with echo, or they are not doing.
No, if they listen the murmur or if there is risk factor, I think then only they're doing. Routinely they are not doing echo for all babies. Like Down syndrome, you know that these children will have some or the other heart problems. You will ask them for the echo evaluation, or you heard murmur, or you did chest x-ray for something and you see some abnormal shape of the heart, something. I don't think routinely they are doing it. Okay, so the causes of stroke was childhood stroke may be due to vascular, that is the vascular accident, thromboembolic or hemorrhagic disease. So the clinical presentation determined by the vascular territory is determined by the vascular territory involved. So in the stroke, what is the most common vascular territory involved? Dr. Shri Devi.
Yeah, middle cerebral artery, and mostly they have internal capsule involved.
Yeah, middle cerebral artery. So the vascular territory involved will give you the presentation. Commonly, there is compromise of anterior circulation, that is internal carotid, anterior cerebral arteries, and the middle cerebral arteries. Okay. So which leads to contralateral hemiparesis with or without hemianopia and speech disturbances. So the common involved vessels, I think most common is this middle cerebral artery. The other can also be anterior cerebral artery and internal carotid, which can lead to contralateral hemiparesis with hemianopia and speech disturbance. Less common is compromise of posterior circulation, that is vertebrobasilar arteries, which is associated with visual and cerebellar signs. Okay, so most commonly involved is the anterior arteries than the posterior. If the posterior circulation is involved, the patient will present to you with cerebellar signs. So what are the causes of stroke? Cardiac. So I think when you're taking history, cardiac has to be addressed, not just asking the awareness of the heartbeat. Okay, any problem she had before in the heart, you can ask a direct question here if the role player did not give you the answer. So congenital cyanotic heart disease, example Fallett's tetralogy, and endocarditis also, if she had previous heart problems, it can be the cause, but here there is no fever, so less likely. The most common cardiac disease which is associated with stroke is Fallett's tetralogy. Okay, so any cyanosis can be asked, but I think you asked about cyanosis, right? I don't remember.
No, I didn't ask about cyanosis.
Yeah, because you did not touch much about cardiac, you just asked only about the awareness of heartbeat. So you have to touch the cardiac here, very important. Then hematological sickle cell disease. Yeah, of course. Okay, after cardiac, hematological, the most common is the sickle cell disease. Deficiencies of antithrombotic factor, protein S. Somebody was asking this, right? So along, not just sickle cell disease, even the antithrombotic factors, protein S, can lead to bleeding. Then post-infective varicella and other viral infections. Post-infective can cause, but I think varicella most likely presents with the cerebellar signs. We have seen it post-infective. Then inflammatory, damage to vessels in autoimmune disease. Yeah, this is very important. So you will also keep SLE in your mind. SLE, systemic lupus erythematosus. Then metabolic and genetic, homocystinuria, mitochondrial disorders, that is MELAS, and cerebral autosomal dominant arteriopathy and subcortical infarct. So you can also remember metabolic and genetic, but I was talking particularly for hemiplegia, which will be a local cause for all these things, metabolic and inflammatory, metabolic and infection, it will be overall rather than in a local particular place. So keep this down for hemiplegia, post-infective and metabolic. Next, vascular malformations, that is arterial malformation or moya disease, in which there is progressive involution of cerebral arteries. Moya comes from the Japanese. 1 minute, I'll change the page. So it comes from the Japanese word puff of smoke, similar to blurred appearance seen on angiography. So you will also, angiography is also the investigation of choice you have to do. Okay. Trauma, dissection of the carotid and vertebral arteries. Trauma is also one of the cause. So many causes we read. We have to make this as the differential. She asked trauma and other things. Main thing she did not touch was the cardiac, I think. Other things and all she covered. Investigation should include an assessment of cerebral and external carotid vasculature with MRI and MR angiogram. And when indicated, MR venography and echocardiography to detect the source of embolism, along with a thrombophilia and vasculitis screen. So what now, this case is stroke for evaluation. You have to do all this workup in this case. Like you will do MRI, MR angiogram and echocardiography to detect any source of embolism, and along with thrombophilia and vasculitis, that is SLE screen, and metabolic tests for homocysteine and mitochondrial cytopathy. Often no cause can be identified. It can be idiopathic also. Rehabilitation requires involvement of multidisciplinary therapy team. Low dose aspirin prophylaxis is recommended for arterial ischemic stroke. If it is diagnosed as arterial ischemic stroke, it will be low dose aspirin. So strokes occurs in infants and children. In infants occurs in perinatal period and may be in late infancy with hemiplegia or with seizures. In children are seen in association with cardiac or sickle cell disease following varicella infection and neck trauma. However, often no cause is evident. So even after ruling everything, still you did not get the cause, it will be often no cause is identified. So it will be like idiopathic. So we can go back and read and make a list of our investigations. So anyone wants to comment about this case? I think this small portion of knowing about it is enough. Anyone wants to add anything or any source? Go ahead.
Just one question, Dr. Noor.
Huh?
Regarding MRV and echo, they said if indicated, I mean, if there is no history suggesting cardiac problem and no in examination, no suggestion of cardiac problem, I should do echo or not?
I think when you don't have any, you did not come to a conclusion of diagnosis, you will go for it. Before labeling that she is idiopathic, you have to rule out everything, right? By chance,
Right.
now in this case, we saw it's clear an infarction. Okay, she presented left side, right? It was on the right side, causing mass effect also. There was some swelling and mass effect there. So if you don't get, you are investigating and you are not getting the cause, before labeling her that there is no cause detected, you have to do the echocardiograph. This is what I think, but I am not sure.
Okay, thanks. Thank
If
you
she
very
would
much.
have asked about cardiac problem, I had kept in my mind to tell her that she had some small hole when she was a baby, like small, less than 1 centimeter, means 1 centimeter or 2 centimeter, which got closed by itself, was followed up by cardiologist. And this is insignificant. I don't think this will cause any problem. Like the muscular VSDs, which gets healed by themselves, they will not cause any problem in their future life. It will be a normal structural heart, right?
Yes, right.
So maybe if it's not that the parents will tell you everything. Sometimes what happens, they may not give you the history. So for the child who is clear in diagnosis, you will not go for it. For a child who is not clear in diagnosis, you will work out completely before labeling him that there is no cause detected for him.
Okay, another point would
Please open your mic.
can you review the team again
What
in
you
this
want?
case? The team, multidisciplinary team, what and it should include?
Review. This is you will involve the multidisciplinary team. This is an acute stroke case, so you will first involve your consultant. You will stabilize the patient with ABC, and the bedside investigation, most important in vital signs, is the BP, blood sugar, and fundoscopy. Okay. Along with the other vitals, I'm telling, the main vital signs which you will be concentrating here will be BP, fundoscopy, and also the what blood sugar. These three things bedside you will do. And then for the team involvement, you will involve your consultant, then the pediatric neurologist, then slowly physiotherapist has to be involved, occupational therapist, speech and language therapist, psychologist because they are in depression, and educational plan has to be put for her, even dietitian. We don't know, she's on 75th centile for her weight. Okay.
Yes.
Yeah, so even dietitian has to be involved. And even if you want social worker, why you said social worker, Dr. Sridevi?
Because it's maybe lifelong, not lifelong, maybe a little bit chronic. So they have to follow.
Yeah, she may
And
go
they
into
require.
special needs
Yeah. Yes.
child till she improves, right? And there is, if
Yeah.
the presentation is not within 24 hours, they say that they will have some sequelae. They may have some sequelae despite your trying hard, but still you cannot say.
I should say also hematologist and echocardiologist, or if I say that after, if the investigation are clear, I should involve them.
For the cardiologist,
Yes, cardiologist and hematologist.
you can add it now, no problem, because here it is not a clear case. If it was sickle cell, you would have told only both neurologist and hematologist. In a clear case, if you want, if you are not clear, you can involve from the beginning, no problem. Actually, they want from us, when this case comes, what do you do acutely and whom do you refer to? This is what they want. Because we will not be the one who will do the echo, or the further tests will be done by the hematologist, right? Yeah, support groups, I think now she is in acute presentation. The history is just days. Once she is out, and once she goes out of the hospital, and depending upon the sequel she has, she can be involved in the support groups. Any chronic child with special needs can involve the support groups, but I am not sure that is there any support group for stroke, or they will join with the same with the hemiplegic CP or something. I'm not sure about it.
Excuse me, Dr. Noor.
Yes.
I have one question, please, to clarify. If is it of importance here to the side of the hemiplegia and the side of the facial deviation? Would it be of importance to know the level here? They might ask something like this.
They might
I mean,
ask
crossed or uncrossed hemiplegia, or is no issue here?
no. In clear cases, they may ask you, because here it is clear, all complete left side is involved, so less likely crossed.
Yeah, uncrossed. It will be uncrossed.
Uncrossed, and we all know that the stroke presenting as clear hemiplegia is the involvement of medial cerebral artery, internal capsule.
Okay.
What
So
is
if we
common
ask,
is common. Yeah.
if we ask about the vision, the visual acuity and speech here, it will be relevant or no
You
need
have
for
to
this
ask.
question?
You have to ask because there is deviation of the mouth, and there will be drooling of saliva. They will have problem in articulation, because for articulation, not just tongue, you need your lip movements, right? Here, due to the deviation of the mouth, your lip movements are affected.
Mhm.
So you have to ask. The speech will be affected here.
Okay.
This will give you a clue. How is the face? Any facial weakness you see, maybe the mother may not answer you about the weakness. Then you can ask any deviation you see, any problem in her speech now, like this.
Mhm.
Okay. I don't know.
As well as
Yeah.
sphincter disturbance as well also.
What?
Sphincteric disturbance. I mean, poo control.
Bladder bowel.
You have to ask. Sometimes it happens. And what happens, not necessarily in a clear hemiplegia in the internal capsule, but they are not able to get up and go. The urgency may cause you to pass it in the cloths more than incontinence. You got my
Oh,
point?
yes.
Yeah, hemiplegia, I don't think it is as such associated with the incontinence of this, but they cannot get up and go, and the urgency may cause this problem.
Okay, thank you.
So I think we will take a break. I don't know if Dr. Muzna, she will give a video or not. If she will not give video, we will do at 7 p.m. Communication. Okay.
Okay.
Okay. Thank you.
Thank you.